Joyce, I'm going to go ahead and play Dr. Kelly's message.
Okay, wonderful.
We're going to get started.
Good afternoon. My name is Dr. Morris Kelly. I'm an interventional cardiologist with CHI St. Vincent, and I'm proud to be the president of the board of directors of the Central Arkansas affiliate of the American Heart Association. The American Heart Association has long been a force for good in communities. The work of the American Heart Association has led to breakthroughs in science, advances in public policy, and a broad awareness of cardiovascular disease and its prevention. We are committed to a more proactive and preventative approach to the underlying issues that cause heart disease and stroke. We understand that heart disease does not happen in a vacuum, but instead is caused by a myriad of community and societal forces, including how safe our neighborhoods are, how strong and supportive our families are, and how invested we are in our communities. We want to further change by being a catalyst for transformation to advance health equity and ensure equitable health for all. According to the Centers for Disease Control and Prevention, 6 of every 10 Americans have at least one chronic medical condition, with 4 of every 10 Americans having 2 or more. We recognize that these chronic diseases disproportionately impact people of color, those without access to preventative health care, and those in lower socioeconomic groups. For example, over 40% of adults in Arkansas are diagnosed with hypertension, but only half of them have it under control. Another area that the American Heart Association is committed to addressing is the discrepancy in the availability of good food choices. 1 in 9 people in the United States struggle with hunger. Here in Arkansas, 13% of residents use some form of the Supplemental Nutrition Assistance Program. Nearly 2/3 of people who receive benefits from the program are children, individuals with disabilities, or the elderly. Thank you for joining us today to learn more about what you can do for your own health and those you care about. Through help like yours, we can create a culture of health.
Thank you. And LaShannon, can you, okay, we can see the screen now. So thanks so much to Dr. Kelly for that opening and for his leadership as our American Heart Association Central Arkansas Board President. And thanks to CHI St. Vincent and all of their many ways of support of the American Heart Association. Thanks to Saline Memorial Hospital and National Park Medical Center, along with Community Health Centers of Arkansas, on helping, sponsoring, and making available our senior health webinars that we're having. We really thank them for making it possible for us to share this important messaging and supporting the important mission of the American Heart Association to be a relentless force for a world of longer, healthier lives. So hello everyone, my name is Joyce Taylor. I am the Executive Director of the American Heart Association, Central Arkansas. We are so glad that everyone is joining us as we continue our community conversations. At the American Heart Association, keeping hearts beating keeps our hearts pumping. Every day in the United States, 2,300 people die from cardiovascular diseases, but the impact reaches much farther. It means a missing loved one at weddings, holidays, birthdays. Heart disease and stroke impact more than just the patient. They break the heart of the whole family. The American Heart Association believes these moments are far too important to let a single one be lost. That's why we have invested in innovative research and bold initiatives that will save and improve more lives. We establish relationships and communities. Just a moment. To work to educate families on how to prevent heart disease and stroke. And we work within our hospitals and through our advocacy initiatives to ensure that every American has the chance to live a long and fulfilled life. However, despite these victories, heart disease remains the single largest health threat to Americans, and stroke is one of the leading cause of disability. You may be asking, what can I do? Well, you can make healthy choices in your own life and encourage your loved ones to do the same. Stop smoking or never start. Make a commitment to move more and eat healthy. It's also important to learn the warning signs of heart attack and stroke. Some heart attacks are sudden and intense, but most start slowly with mild pain or discomfort. Pay attention. Pay attention to your body and call 911 at the first sign of a heart attack and stroke. Your life is too important. Don't die of doubt. Today's American Heart Association Senior Health Community Conversation, along with Community Health Centers of Arkansas, is sponsored by CHI, Saline Memorial Hospital, and National Park Medical Center. A very sincere thank you to them and for making these available. Each of the series are going to be taped and they will be made available by reposting on our social media accounts. Please join American Heart Association's Facebook account at American Heart Association-Arkansas. Join and share and like our Facebook page and share these presentations out with your family and friends. Make your post public, if you will. Please, let's put this important information that we're learning together today and to good work and help save lives. And for today's presentation on cardiovascular diseases and vulnerable populations, I am pleased to introduce you to our presenter, Dr. Jason Pelton with CHI St. Vincent. Dr. Pelton is an interventional cardiologist with expertise in a broad spectrum of cardiovascular diseases. He makes every effort to diagnose and treat patients of all ages with empathy and create individual treatment plans that deliver the best outcomes. Dr. Pelton.
Hi, thank you for having me. Is this a Q&A or is this just a kind of talking and discussing?
Well, it can be a little bit of both, but we'd love to hear from you, and if you would share some messaging with us, and then we would like very much to offer question and answering.
Okay. Yeah, so I am originally from here in Arkansas, but I did a lot of my training, actually most of my training in Houston, Texas. So I've been back here for about 4 months now. So I'm excited to get back to the state that I'm from and make a good contribution to the health of not only Hot Springs but the entire state. As we know, Arkansas doesn't do very well nationally in mortality rates for a lot of diseases, and a lot of that is due to socioeconomic factors and high rates of obesity, low education. So I think it's very important for us to try to bridge that gap, as best as we can, because this is a problem that's not only bad now, but it's getting worse in the future. And we're seeing it in younger and younger ages as well, not just, in the elderly. And so it's important to kind of focus all of our efforts on prevention, because that's really kind of the most important thing we can do to slow the pandemic of cardiovascular disease. Anything in particular you want me to discuss?
Well, Dr. Pelton, what do you think the biggest challenges are right now for your patients during COVID-19?
I think a large part of it is, there's a fear to get out. I think that's, people are worried about getting exposed unnecessarily. So I have noticed that people, maybe aren't going to their appointments like they should do. They're not going to the pharmacy to refill their medications. And, a lot of times, you become so fearful of other things that you neglect, really it's still the most common cause of death is cardiovascular disease. So I think it's important to keep that in mind, because the medications we have are very effective at reducing the risk of death and the risk of heart attacks and strokes. And so it's important to stay on top of that. And then if people, obviously when they get COVID are at much higher risk of complications, when they have pre-existing cardiovascular conditions, hypertension, diabetes, prior cardiac disease, prior MIs, congestive heart failure. And so all those things add to the morbidity and mortality of the COVID virus.
And you mentioned young people. You're seeing more young people?
We are. I mean, we're seeing, we've seen people as young as 20, in their 20s and their 30s. Obviously those are fortunately pretty rare. But nowadays with, the obesity issues and people are getting diabetes at younger ages, people are still smoking at high percentages, and all those things together, unfortunately, are a very dangerous combination. And then also when you take into account that we're just not as active, as a society as we used to be, our diets have changed. We're eating more processed foods, we're eating higher salt, we're eating a lot more sodium, and all those things together, are causing this issue. And unfortunately, all the cheaper foods happen to be the worst foods that you can get. And so, when you have, a state like Arkansas where, there's a lot of people that rely on food assistance, a lot of times they can only afford, maybe something that, like, if they go to McDonald's, they'll get a good meal for $5, but that $5 also calories. I think we need to do a better job making health more accessible and cheaper.
So anyone's welcome to ask Dr. Pelton questions if they'd like.
Hi,
Yeah.
I have a question from Northwest Arkansas, and I know obviously in primary care, in pediatrics, seeing kids and working with their families, but many of us across the state also have school-based health centers, and in talking about just prevention and working with families and the school systems, especially thinking of kids and trying to prevent the onset of these types of diseases. Have you seen any kind of work being done across just healthcare systems and the school systems, especially when we have clinics embedded in the school-based systems?
I've only been here for a few months. I do know that in Hot Springs, we have a lot of outreach with the Sweetheart program through the American Heart Association. I know they do a lot of community outreach through there. My wife is a school teacher. She's not working this year because we just moved from out of state. But I think that the earlier we can make an impact, the better. We know that atherosclerotic disease does begin as young as your teens and your 20s, depending on your risk factors. And these things are things that we can prevent largely. And so I think it's important that, when we do have, the ability to make an impact, I think we should. I haven't seen the clinic, the school-based clinics here in Hot Springs. I don't know if that's an option. Is that something that is common in Arkansas, or?
I can only speak, our system has 8, and I know there are others, so I'm not sure if anyone else on the phone can answer for their systems and their areas.
Okay.
Dr. Pelton, you talked about prevention, and we all know that obviously we need to dial 911. We need to get in for emergency care if we're having symptoms of a heart attack or stroke. But beyond that, just on the preventive side, when should we, besides our regular general physician, when should we go in for tests or screenings or stress tests?
A lot of that depends on what your overall risk profile is. If you have a strong family history, usually we look at first degree relatives, so siblings, children, parents, anybody in that realm of a family. If you have a strong history of coronary disease or stroke, especially at young ages, so anything 50 or less, generally 55 or less, should maybe have a little bit more focus on it. If you have elevated blood pressure, even though if you don't have a diagnosis of hypertension, there's a large percentage of the population that, their blood pressure is above, 130/80, even though technically that's not hypertension, that still puts you at a higher risk. I think everybody should be screened for lipid disorders, high cholesterol. They should be screened for diabetes if they haven't already been. And once you get those risk factor, identification, if you have them, depending on your age and other factors, you can undergo cardiovascular screening with, some people do calcium scores. Some people do, if you're really high risk, then stress testing is indicated, even in the absence of symptoms. And then, but everybody should get screened, as soon as they become of adult age. And we're seeing even kids. I've got several people in their 20s and 30s that have been referred to me for hypertension, and it's not just mild hypertension. It's they're on 3 or 4 medications already, and so I'm seeing that more often. And so the idea, like I said, is to I'm an interventionalist, so I love doing procedures. I love doing complex cases. But we really make the biggest impact on the front end, and all that's about 20 years before all those things happen. So,
Right. Kind of around hypertension, we do have a question in the chat box. I'll read it to you. I see hypertension listed as a higher risk for many things. If a person takes medication for their condition and numbers improve, are they still at higher risk?
They're at a little bit higher risk, but they're not. Their risk is pretty similar to like a general population. If their blood pressure is well controlled, their risk profile is generally about the same as somebody that does not have hypertension. But just in the fact that they're on medications, they do have a slightly higher risk. But the risk is definitely mitigated.
There's so many people that they say my blood pressure is up or it's down, and they kind of self-medicate. They skip a pill or they take another or something. What would you be your advice around that?
A little elevation, elevation in blood pressure is normal, especially if you're exercising. So if you do check your blood pressure, I would recommend waiting at least 5 minutes, at rest, and then taking it 3 times, a couple minutes apart, and then averaging it. That's really the best way to get an ambulatory blood pressure. And many people, they go upstairs, get their machine, they come back downstairs and they check it, and by then it's elevated. And so, but really the best way is to do it at a resting state. In terms of missing pills, a lot of them, the medications rely on being at a steady state in the body and in the bloodstream. And so when you adjust medications like that, you actually are altering the levels in your blood. And so, you really need about 4 half-lives or 4 or 5 half-lives of the medication. And usually that's, 2 or 3 days to really notice a difference. So if you're skipping a pill here and skipping a pill there, you're really kind of altering that balance. And so you can have the lability that we see in a lot of people where their blood pressure one day might be systolic of 110, the next day it might be 150. And so I think keeping your medications as prescribed really gives us the information that we need, especially if you're keeping track of it, to make medication adjustments. Making adjustments kind of on the fly is not something I recommend, because you can have rebound hypertension with a lot of medications, and that can be dangerous. It can increase your risk of having a sudden stroke, especially hemorrhagic stroke, which can be devastating. And then, if you have any vascular conditions like aortopathies or disease of the aorta. You can have ruptures of aneurysms, and so I think it's a good idea just to keep everything the same. If you have a question about your medication, discuss with your physician and let him or her guide you in that discussion.
Here's another question from the chat box. I know you are interventional cardiologists. Are there any new interventional procedures on the horizon that we may not know about?
There's always new things. I was on a webinar similar to this one last night with the Biomed. They develop percutaneous ventricular assist devices, which are devices that support the heart in high-risk procedures and in patients that have shock related to heart conditions. And everything's getting smaller and smaller. Our equipment's getting smaller, which also means safer. Our stents are becoming better and better. The stents, 15, 20 years ago, it's just bare metal stents. After 6 months to a year, you'd have to have another one. And so we came out with the drug-eluting stents, which are they have a polymer on them that elute medication that are anti-inflammatories, and so those reduce the risk of re-narrowing over time. And now we're kind of on our third generation of stents. So the stents are getting better. Our equipment deliverability is getting much easier. We are, now the new thing is structural heart disease, valve conditions, mitral valve, pulmonary valve, aortic valve. And we're getting to do things that you can only do with surgery, 20, 25 years ago. Now we're able to do them, where you can go home the next day. And so that's all very exciting, especially in an aging population that has a lot of comorbidities. Surgery may not be suitable for them. They may be at higher perioperative risk. And so the ability to do those things that we, historically haven't been able to do is very exciting. I've sent patients that are over 90 years old for these procedures, and they do remarkably well. They go home the next day, and they feel much better. Their endurance is better. They can spend less time in the hospital. They can spend more time with their families, and so that's the goal.
You also mentioned something about if patients bring in their blood pressure readings. Do you encourage that? Do you ask them to do that? And if so, what is the most helpful to a doctor to see?
Yeah, so generally, when patients come in, you hear this term like white coat hypertension. That's a very real thing. We see it. I see it every day. They come in and for whatever reason, just they're nervous or they're anxious or they're scared. There's kind of an unknown factor when you go to a cardiologist. And so the blood pressure, may reflect that. And so I give everybody that I have diagnosed with hypertension or I suspect it, I give them a log to take home. Have them take their blood pressure every morning. You want to do it before you eat, not after, at rest. And then, you write that down. When they do that for 2 or 3 weeks at a time, you really get an idea of what their day-to-day blood pressure is like, because sometimes they're not, when they're seeing us in our office, they've been fasting, and so their blood pressure may be off just because they haven't eaten anything. Their sodium load may be lower because they fasted. So you get a good idea of where they're at in terms of blood pressure monitoring. But I think it's the best way to check it. And then you also know if they're being compliant with medications or not, or adherent. If their blood pressure one week is controlled and the next week is not, you can ask them, did you eat something different? Did you go to a restaurant that you don't normally go to? Did you run out of medications? And then you can get into the discussion of, why are these things happening? Especially if you've documented control on this medication regimen, why is there a sudden change? Is something I need to be looking for that's new or different? So, if you're on blood pressure medicine, you should definitely be keeping track of it. Maybe not every day, but at least, a few times a week. Come down, keep them on your phone. I've noticed that a lot of people keep them on spreadsheets. I've seen that pretty often, especially in our older population. They seem to be very good at keeping track of these things. So it's, it's definitely helpful.
Well, kind of along that lines in the chat box, should you take your blood pressure at the same time daily or different times if you're having hypertension issues?
So if I'm having somebody that's difficult to control, generally I'll have them do it twice a day. I'll have them do it in the morning, after they, maybe like 30 minutes after they've taken their morning medications, and I'll have them do it in the evening before bedtime, just to see if there's any nocturnal fluctuations, because sometimes the medications, even though they're once a day, the effectiveness may wear off towards the end of the day. So I may have them maybe take one at night instead of the morning, and so you can adjust them and fine tune them, especially if somebody's having a hard time getting them under control. Once they're controlled, I think once a day is fine. It can be morning, it could be evening, but as long as it's the same time of day, just to keep it consistent. Similar to weighing yourself, you don't want to weigh yourself at different times of the day, just because it can create variation, and as little variation as possible is always the best.
So the American Heart Association was part of forming a heart failure coalition among medical professionals in the state. And sitting in on those meetings, it seemed to me that they kept reporting that the patients, they didn't understand, or they just weren't educated. They were leaving after their incidents or their treatment or their care, and they didn't know how to follow up. I mean, what does hospitals or clinics do to inform patients once they have a serious incident? I mean, what happens next?
Yeah, so heart failure, it's one of those conditions where the readmission rates are extremely high. Definitely higher than probably most other medical diagnoses. Unfortunately, heart failure is one of those things where any sudden change in kind of our body's status quo, can kind of tip you over and put you into an exacerbation, whether it's diet, whether it's missing a single dose of your medications, whether it's, just not understanding when to take your medications. And, I think, ideally, if somebody is discharged with a heart failure diagnosis, they really should be followed up within 1 to 2 weeks, and ideally within a week. Some places have heart failure nurses that do follow-up calls just to check on the patient, make sure they're doing well, make sure that they have all their medications that were prescribed to them, make sure that they know how to take their medications. Dietitians are very important in the hospital to discuss things to avoid in terms of salt, excess fluid, things not to eat, things that are beneficial to eating. And then not only in the hospital, but also on follow-up, when they come and see us, we need to be having these recurring discussions, because it's very easy to forget, when you're getting so much information thrown at you in the hospital, to remember every single thing. We know that patients and just humans in nature, if you give them too much information, they aren't going to remember it. And so just that reinforcement every time you see them, nutrition, medication adherence, things to watch out for, weighing themselves every single day, keeping track of what they're putting in their bodies, how much water or fluids are they taking in, how many times are they going to the bathroom every day. Those things are something you have to keep on top of. Because heart failure, we know, the more hospitalizations you have, the worse your outcomes are, long term, the higher your risk of death is. And so the longer we can keep patients out of the hospital, the better.
You talked about congestive heart failure, and I remember years ago when my father was being treated, and we were in an exam room, and they said, well, he's in the midst of congestive heart failure, and it scared us. We thought something immediately was going to happen, but then they said he's been living with it for years. I mean, will you talk about that? I mean, what does congestive heart failure mean, and what does that mean to the patient?
Yeah, so congestive heart failure, really means that your heart is unable to keep up with the metabolic demands of the body. About half the people have systolic heart failure, which is where the muscle of the heart is weakened for some reason. The other half of patients have congestive heart failure because their hearts are too stiff and don't relax as well. And they're about 50-50 in terms of prevalence. We have really, really good medications for systolic heart failure that have been very well studied. They're life-saving, they reduce hospitalizations. The medications, we also use them for the diastolic heart failure, which is the other side of it. Unfortunately, the medications that we use for systolic heart failure haven't borne out to be as effective for that one. And so it's a little bit more difficult to treat because, we don't have great data on that specific condition, but the treatment more or less is the same. Some people need diuretics to reduce the amount of congestion they have. Some people don't, depending on how compensated they are. Our medications are very good, whether it be beta blockers, ACE inhibitors, ARBs, medications like Entresto have been shown to be very effective. And spironolactone is another one that's been well studied. And so all these things, we have a lot of tricks in our bags and tools to use to extend the life of these patients. And I think that's why you're seeing so many people now living with heart failure for 10, 15, 20 years, when 25, 30 years ago, that just, that wasn't the case. And so then that goes back into the, patients are getting older, they have more medical conditions. They've been having heart failure for a long period of time, they're living longer. And so now we're seeing this, as an interventionalist, people with a much more complex coronary artery disease, very calcified coronaries, difficult to fix. Fortunately, we have tools to do that now. And so when you add all those things together with the technology and the medications that we have, it's been a good thing.
Another question from Gillum. What kind of telehealth monitoring options are useful for these patients?
So the weights, monitoring the weights is very helpful. I trained in Houston at the Michael DeBakey VA. Their telehealth program provides a scale to the veterans, that you prescribe it for, and they weigh themselves every day. And you have a nurse basically that's monitoring their weight. And if they see it, if they see a big change and they intervene at an early time, that's very helpful. And I always, kind of educate my patients, to weigh themselves every day. If they notice a, 2-pound weight gain in one day or a 5-pound weight gain in 1 week, that's really where you want to intervene early, increase their diuretics, have them come see you in clinic to see if there's something going on. And a lot of it is just something as like, oh, I went to whatever fast food restaurant, ate some fries, and I'm retaining more fluid. But if we know that the earlier you intervene, you can keep them out of the hospital, you can manage them as an outpatient. But if you don't intervene, sometimes 2-3 weeks down the road, they've gained 30 pounds, and you've kind of missed the boat, unfortunately. And then they have to be admitted to the hospital for treatment. But a lot of these admissions we can prevent just by intervening early. Weights are a good thing. Not everybody can keep track of how much urine they produce. That's very difficult, but weight is the best surrogate for that, as long as you're not dieting or you're not eating excessively. The weight is a good marker of fluid status.
It's very interesting. Also, out of that Heart Failure Coalition, they talked about tools that people needed. You said that weight or scales were provided for VA patients. And so we had talked about what could we do to assist with heart failure patients that with tools like that, like blood pressure cuffs and weight scales, maybe pill boxes so that they take their medicines more regularly. Is there anything else that would be helpful? I mean,
all those things are good. They have a device now called CardioMEMS that is in the process of getting approved by the FDA. It's a device.
Will you repeat that, Dr. Pelton? What was the
CardioMEMS? Yeah, so it's a small device that's implanted. It's a procedure that you implant a small device in one of the lung arteries, and it monitors basically lung pressures. And it's been shown to reduce hospitalizations, reduce admissions. And so some hospitals are using that. as a, especially for patients that are getting admitted frequently and they're having a lot of exacerbations. That's been shown to be effective. I think that'll probably increase more and more now that the FDA is in the process of approving it. And that's made by Abbott, I believe. And as opposed to that, I mean, that's the kind of invasive way. But scales are cheap nowadays. I mean, they're 15, 20 bucks for a digital scale. Blood pressure machines are probably about 20, 25 bucks. And so if you add those two things together, a pill box is probably about $5 more or less. I mean, that's $35, $40. And if you reduce one hospital admission for a patient, that could potentially be thousands of dollars. I mean, I think the cost benefit would definitely be worth it. And I think we're moving more and more into that, is to lower healthcare costs, is to be intervene early, get people the equipment that they need. One of my biggest kind of peeves is sleep apnea, management of sleep apnea. It's a very common cause of morbidity, and it leads to high blood pressure and arrhythmias and heart failure. But a lot of people can't afford the machines to treat the sleep apnea. You can diagnose it with a sleep study, but what do you do about it? And so, a lot of people have to either get refurbished machines, or they just can't afford them, because they're a couple $100, $300, $400. But if you use them, you think 5 years, 10 years down the line, how many hospitalizations can we prevent? How many complications can we prevent? And when you add it up, it's millions of dollars for, just a little bit of investment up front. So that's kind of one of the things that, I think we could do a better job of, especially now that, now with healthcare costs rising as they are, just to do a little something to improve that.
Now, don't let me deter anyone from asking questions, because I'm loving this and I'm just going to keep going, but jump in anytime, anyone. Unmute and ask questions. Dr. Pelton, will you talk about, is there any difference in women and men? We know that they have different symptoms, but, what do you see around that? And then what about treatment and care?
So, I mean, you're taught in medical school and training, what we call typical chest pain or typical angina, which is another word for chest pain. Very rarely do people present in a typical manner. The textbook definition of angina. More often than not, there are some atypical qualities to it. The classical teaching is, angina or chest pain is substernal, pressure, squeezing, tightness, radiates to the left arm, radiates to the left side of your neck or jaw. It's predictably with exertion. The longer you walk, the more severe it gets, and then it goes away once you stop, or if you take, a nitroglycerin tablet, it goes away. That's kind of the classical teaching, but very rarely do people present that way. Women are notorious for having atypical symptoms. They can have something as abdominal discomfort, or nausea, or shortness of breath, or the pain might be down their right arm, or their pain might be in their back. And men have the same thing. Men are more prone to have typical symptoms, but women, especially women that are diabetics, can present different ways. And unfortunately, women statistically don't do as well in terms of cardiovascular outcomes as men. And I think as providers, we have to do a better job of identifying these and not just dismissing them like, oh, it's not cardiac, it's their stomach, or oh, it's musculoskeletal, or it's anxiety. I think, unfortunately, that's done quite frequently, unfortunately, and we need to do a better job of kind of delineating that. And men typically present younger. Women, because estrogen is protective, they present about 5 to 10 years later, typically, than men. And so, not to say that they don't present earlier, but that's generally the rule. Yeah, women, I think, is it's an area that we definitely can improve on. We've been improving on a lot of areas, but that's one area that we can definitely do much better on.
And what about children? Kind of the same question for children.
So children typically, unless they have some anomalous anatomy, or they have some other congenital issue, typically don't present with with cardiac disease, usually that's, if it's something that's pretty severe, they're found at birth, generally with an exam, have a murmur on exam. My son was diagnosed with a VSD at birth, and fortunately many of those closed on their own. So we were fortunate that happened. But there's a lot of times congenital disease doesn't go diagnosed until they're in their 20s or their 30s. A lot of times it's vague symptoms like, oh, I can't do as much as I did a couple years ago when I was jogging, or they'll get an ultrasound done for some other reason, or a CAT scan done for some other reason, and you'll find these abnormalities. And so, we do see them. You'll see things in pregnancy often. People, young women will get pregnant. They never had any issues, but pregnancy, it alters the volume of water in our body, or not our, but in women's bodies. It alters the flow of blood. And so that'll a lot of times be the first time women are symptomatic is in pregnancy, especially if they have an undiagnosed congenital defect. And most of these things can be corrected non-surgically. They can be corrected in the cath lab, for example. VSDs can be closed, ASDs can be closed. Those are septal defects in the atrium and ventricle. Coarctations, which are narrowing of the aorta, can be corrected oftentimes non-surgically. And so, it's an exciting time to be a cardiologist because you get to do a lot of different things.
Okay, so I'm going to ask one more question and then I will stop. And so I'm going to give anyone else a chance to ask a question too before we close out. So, Dr. Pelton, what about everything that we've been living through and going through with the pandemic? It's stressful. I mean, have you seen more patients because you feel like around stress?
Definitely. I mean, stress is a big component to cardiac disease. There is such thing as a stress-induced cardiomyopathy. I've seen that a couple of times since I've been at CHI St. Vincent. Stress releases hormones that can cause narrowing of the arteries. It can tighten the arteries, similar to a muscle spasm. That can lead to chest pain, especially in somebody that has pre-existing coronary disease. It increases inflammatory markers in our body that can also cause heart attacks and strokes, things like that. It can raise your blood pressure. So somebody already has blood pressure issues, and the more stressed they are, their blood pressure goes up. That can lead to complications. So it's always a good idea to, do what it's difficult now just with everything going on. But whatever you enjoy in life, that's whether it's exercise, whether it's playing with your children outside, whether it's reading a book, whether it's just do something you enjoy that can help you forget about all the extraneous stuff going on. Not only with COVID but with the election. That always kind of ends up being a stressful time, I think, for everybody, regardless of what side of the spectrum you're on. It'll be interesting, over the next 6 months to a year, as we get, hopefully COVID starts easing, out of our lives, how things look and how, hopefully we'll have a fresher perspective on life and be able to enjoy it more once we're able to relieve some of these other stresses that weren't here a year ago.
Yes.
Joyce, that was a great question. You actually took my question because of the uptick in stress. And Dr. Pelton answered it very well, just the stress-induced, issues that comes along with it. Dr. Pelton, anything we could do from a holistic perspective to help eliminate cardiovascular disease?
In terms of like pharmacologic or just in general, just overall well-being?
Overall well-being.
I think, my stress reliever is watching TV. It's as sad as that is. I kind of can escape for a little bit. I work long hours, and once I get home, I've got to get have my wife get the kids fed and get in bed, and so once that's done, it's about 8:30, and so I have a couple hours to unwind. So my wife and I have been watching Yellowstone on Amazon Prime, and so that's kind of our kind of time to just be by ourselves and relax and not deal with we don't generally watch the news right now just because of everything that's going on. But definitely when you go on social media and all you see is just badness everywhere, It can be kind of disconcerting just as a human being to see everything that's going on in the world, not just in America, but, really everywhere. But I think everybody, has something that they enjoy. I think exercise is a great stress reliever. Walking outside for just 30 minutes, especially when it's, like today, it's a beautiful day outside here in Hot Springs, a little bit chilly, but just go outside and walk around for 30 minutes and just look at the trees, look at the sky, just take it all in and try to block out everything that, is weighing you down, whether it's your job, whether it's your, family issues or financial issues. A walk outside is free. You don't have to pay to do it. And it's generally, enjoyable. And I think that's, or yoga, some people do Pilates, whatever your outlet is, talking with a friend on the phone, that you haven't talked to in a while, you haven't seen in a while because of COVID. I think those are things that we need to do just to keep our humanity. It's been difficult, I think, for everybody not interacting with their family members or their loved ones for the past, 10, 11 months. So, and especially, for older people that, maybe their kids are grown or they're, maybe they don't have as many friends, as they did 20 years ago. They may be more worried about their exposure. And so, if you have a relative that's older, give them a call, talk to them, and ask them how their day was. I think it'll help you, it'll help them. So, kind of my advice. Everybody has a different way of coping with stress, and some of them good, some of them bad. But try to keep them on the good side.
So basically, breathing the fresh air from outside is good for us. Is that what I'm
Yes,
hearing?
definitely.
Good for our lungs?
Yeah. Good for our lungs. It's good for our souls. I think that, fortunately I live in a neighborhood that has good walking, so try to do that. And if it gets too cold, just bundle up, I guess. hopefully it doesn't get too cold for a while, but, just get out and like you said, smell the roses, get some fresh air.
Thank you. Thank you, Joyce.
Yes. So thank you so much, Dr. Pelton. What great information. We really appreciate you spending this time with us today. Thank you everyone for joining us. If you would like to rewatch Dr. Pelton's presentation, invite others to see it or share it out with your family and friends. All 5 of our recordings on senior health community conversations will be posted to our social media next week at American Heart Association-Arkansas. Please share those out to other seniors, caregivers, to anyone of any age. We all need to educate ourselves for best health and that great advice on stress relief as well. I'm going to close today by reminding everyone of the warning signs of heart attack and stroke. Dr. Pelton covered these, but just as a reminder, heart attack warning signs: pain or discomfort in the chest, lightheadedness, nausea, vomiting, jaw, neck, or back pain, discomfort or pain in arm or shoulder, shortness of breath. Women's symptoms can be very different: fatigue, flu-like symptoms. I had a friend that was just sweating. She knew something was wrong. One of our renowned women researchers, Dr. Jean McSweeney, reminds us that if you get fatigued just making up the bed, something's wrong. We can expect to get a little fatigued, breathe a little hard if we climb a flight of stairs, but if just throwing a blanket over the bed is causing us to have to sit down and rest, something's wrong. Know your body and take action. Stroke warning signs. Remember our little reminder: FAST, F-A-S-T. So for F, it's face drooping. A is for arm weakness. S is for speech difficulty. And T is for time. Do not delay, do not waste time, call 911, get care. So again, don't die of gout, Don't delay treatment or care in an emergency situation, and especially if you are experiencing any of the symptoms we talked about, especially during COVID-19. Don't die of doubt. So we thank you all for being with us, everyone, and for attending, and we wish everyone longer, healthier lives. Thanks so much to everyone. We'll sign off now. Have a great day.
Thank you for having me, guys.
Thank you. Dr. Pelton. Thank you all. Bye-bye.